Hello and welcome everyone. In this video we are going to discuss about iron. Introduction. Iron is a mineral essential element for almost all living organisms as it participates in variety of metabolic processes including oxygen transport, deoxyribonucleic acid synthesis and electron transport. It is also an essential element of heme within hemoglobin. The hemoglobin is a protein responsible for transporting oxygen throughout the body. Disorders of iron metabolism are with diverse clinical manifestation, ranging from anemia to iron overload and possibly to neurodegenerative diseases. Now let's learn about transferrin. Another protein important for iron is transferrin. Transferrin has a high affinity to ferric iron. It is blood plasma glycoprotein that plays a central role in iron metabolism and is responsible for ferric iron delivery. Transferrin divides into subgroups. These are serum transferrin, lactotransferrin, and melanotransferrin. Hepatocytes produce serum transferrin found in serum, CSF, and semen. Mucosal epithelial cells produce lactotransferrin seen in bodily secretions such as milk. Lactotransferrin has antioxidants and antimicrobial and anti-inflammatory properties. All plasma iron is bound to transferrin. The transferrin bound iron complex turnover rate is about 10 times a day, which is essential to meet the daily demands of erythropoiesis. Transferrin acts as a balance between reticuloendothelial iron release and bone marrow uptake. Once iron is bound to transferrin, it is transported by transferrin to bone marrow for production of hemoglobin and portion of erythrocytes. The human body loses iron through perspiration, epithelial cell desquamation, and menstruation. Iron loss is obligatory and there are no specific means to regulate it. Iron homeostasis is hugely dependent on tight regulation of absorption, which occurs mostly in proximal intestine. The iron-bound transferrin is vital to distribute iron to different cells of the body. Ferritin. Ferritin is a cytosolic protein. Ferritin plays an important role in storage of intracellular iron. It is 24 subunit protein that is composed of two types of subunits termed H and L. H refers to original isolation of isoform of ferritin from human heart, which are rich in H subunit, or to its electrophoretic migration as a heavier of the two subunits. L refers to ferritin isolated from human liver, which is rich in lighter subunit. Genes encoding the H and L subunit of human ferritin are located on chromosomes 11q and 19q respectively. Pathophysiology of iron. The food we consume has iron in two forms, heme and non-heme. The elemental iron is released from its bound form in the food by action of hydrochloric acid in the stomach. The ferric form is enzymatically reduced to ferrous form and then absorbed in the gut by divalent metal iron transporter located on the apical surface of intestinal epithelium. The heme form of iron is absorbed directly through a heme transporter. The absorbed iron can be stored along with apoferritin, an iron storage protein in erythrocyte, or can be absorbed into blood through ferroportin. Ferroportin is a transporter present in the basolateral surface of enterocytes. Before being transported into the blood, the ferrous iron is converted to ferric form by Hephaestus. The ferric ion is then picked up by apotransferrin. Evaluation of iron status. It is best performed by assessing a serum ferritin and transferrin saturation. Serum ferritin represents the level of iron stores in the body. The reference range for serum ferritin varies across the laboratories, but levels of 30 to 300 Ng per ml are considered normal for men and 10 to 200 Ng per ml for women. The serum ferritin value less than 30 Ng per ml is generally considered diagnostic of iron deficiency. less than 10 to 15 Ng per ml is 99% specific for iron deficiency anemia. Transferrin saturation of under 20% generally indicates iron deficiency. TIBC, that is total iron binding capacity, is an essential test used for the diagnosis of iron deficiency anemias and other disorders of iron metabolism. Iron binding capacity is the capacity of transferrin to bind with iron. Iron binding capacity is of two types, TIBC and unsaturated iron binding capacity, that is UIBC. The implementation of iron therapy can be initiated based on several different guidelines depending on the etiology. This picture shows the test and reference value. The reference value for serum iron is around 42 to 135 microgram per dl. For TIBC, 250 to 350 microgram per dl. For transferrin saturation, it is 20 to 55%. For ferritin, it is 40 to 160 microgram per ml. The formula for transferrin saturation is serum iron upon TIBC into 100. Now let's understand the mode of administration of iron in case of iron deficiency anemia. First is intravenous iron. Iron therapy in the intravenous form consists of an iron hydroxide core encased in carbohydrate ligand. After administration, these complexes are taken up by macrophages via endocytosis. Once inside the macrophages, they can either be expelled into serum as a ferrous ion or incorporated into ferritin for storage. The iron expelled from macrophages is quickly oxidized to ferric iron and bound to transferrin for transport of iron to target sites. Oral iron. The iron administered orally travels to the duodenum where it is taken up into enterocyte along the brush border by divalent metal ion transporter 1. Most of iron is incorporated into hemoglobin and myoglobin and rest is stored in macrophages with storage protein apoferritin. The daily requirement of iron in adult is recommended as in men and non-menstruating women is 8 mg. In menstruating woman 18 mg, in pregnant woman 27 mg. The treatment of iron deficiency anemia. In iron deficiency anemia, 100 to 200 mg elemental iron is given daily divided into 2 doses to adult patient. For severe iron deficiency or with oral treatment fails or in patients with impaired intestinal absorption, intravenous therapy is must. There are few contraindications of iron treatment and they are hypersensitivity, hemochromatosis and first trimester of pregnancy. The cumulative dose for repletion of iron is based on patient's HB and body weight and should not be exceeded. There are two methods for determining the cumulative dose. First is ganzoni formula and the simplified method. Ganzoni formula. The total body iron deficit is equal to body weight in kg into target HB minus actual HB in gram per liter into 0.24 plus iron depot in milligram. For example, a 70 kg female with hemoglobin 80 gram per liter has an iron deficit of 70 into 150 minus 80 into 0.24 plus 500 is equal to 1676 milligram, approximately 1700 milligram. The simplified method. The following table can be used for estimation of cumulative amount of iron required to replete the body iron stores. Monitoring. The hemoglobin level should increase by 2 gram per dl within 4 to 8 weeks of initiating therapy. The ferritin should be rechecked 8 to 12 weeks after completion of treatment as normalization of ferritin levels and transferrin saturation is a target goal. In case of iron toxicity and patient is hemodynamically unstable, they should be treated with IV fluids and desferoxamine, a chelating agent that can bind to iron and be excreted renally. Injection administration of 20 mg per kg or more elemental iron can result in symptoms of toxicity. And toxicity correlates with amount of elemental iron with iron products ingested. So these are the references for this video. Thank you. Bye. See you in the next video.